Good afternoon, dear friends, colleagues, and also our special guest from France, Professor Gabriel Steck. Today, it's a big honor for me and also Dr. Bambang Budiono as a co-chairman to moderate a very interesting distant learning topic on interventional cardiology. And the title will be the Optimizing the Benefit of Antipatelet Therapy in the High-Risk Post-PCI Patient. This is the 25th event of our distant learning for our member of Interventional Cardiology, our member of Indonesian Heart Association, and also our colleague doctors who are interested in atherothrombosis. Because today, the AstraZeneca company, it's really great and helped us to organize, to have one very outstanding speaker, Professor Gabriel Steck, who currently is head of Department of Cardiology, Hospital Bichat, north of Paris, France. Of course, we will have one speaker from our Indonesia is Dr. Doni Firman, who are already well known as the chairman of the Indonesian Society of Interventional Cardiology. So we will have at least 90 minutes event, and the learning objective of our program, I hope you can read in the monitors. First is to understand the impact of COVID-19 pandemic, especially to the SCS patient. And then to understand the change of practice in the management of SCS during our pandemic era. The third and fourth, we will review and explore the new evidence and the recommendation on the use of double antiplatelets in the post-PCI patient, and also to understand the optimal duration of depth in post-PCI based on the ischemic and bleeding risk. For this, I think Dr. Bambang Budiono will help me to moderate the session. Dr. Bambang, please, you introduce Dr. Doni, and we will start the first speaker.
Yeah, thank you, Dr. Sunaria. Good afternoon, everyone. So we all know that timely revascularization is the standard of care for patients presenting with ACS. And COVID-19 pandemic era has changed our daily clinical practice with regard to prevention of infection by assuming that all of patients are suffering from COVID-19. So this afternoon, Dr. Doni Firman will bring up current issues, especially in Indonesia, regarding PCI in ACS during COVID-19 era. What can we learn? As Dr. Sunaria mentioned before, that Dr. Doni Firman is the director of cath lab in National Cardiac Center Harapan Cita, Jakarta. He is also the chairman of Indonesian Society of Interventional Cardiology. Without further ado, I'd like to invite Dr. Doni to share his views concerning this issue. Dr. Doni, please.
Thank you, Dr. Sunaria, Dr. Bambang, for the nice introduction. So it's been an honor for me to talk, in same state with Professor Steck. So my duty this afternoon, so I will talk regarding the PCI in acute coronary syndrome. And then, of course, we know due to the pandemic, there is some changes, big changes already happen all around the world, and also including Indonesia, of course. So, so my talk is going to be short because just an introduction. I think my talk will not last until 20 minutes. I hope so. So we know that COVID-19 pandemic showing a big impact on the diagnosis of treatment, especially in patients with acute coronary syndromes. And then we must put in our mind that the infection status of each new patient very, very important to us, how to make it or to help reduce the spread of the infection. And then, of course, it's also important that we must provide our healthcare workers, including us and our nurses, the proper PPE, especially in the lab. So this is my slide. In Indonesia, we often see it almost every day. This is in Indonesian language, in Bahasa. You can see every day the new cases still rise. I don't know what about in French. I think is probably much more stable comparing in Indonesia. And then so far we have around 60,000 cases, and then 3,000 died. So the case fatality rate is around 5%. So we know in the beginning of COVID-19 in Indonesia, we started this pandemic around the end of the February of the early week of March. We learned that initially that COVID-19 will affect only to the lung or respiratory tract. And then we also learned lately that COVID-19 also have a direct effect on the myocardial. And then we also learned in the latest weeks that the COVID-19 also have related to the atherothrombosis. Might be it will impact the pulmonary artery, but also even in the coronary artery, and then will induce acute coronary syndrome. And if we have a patient with CV comorbidities, you know, it's very common, especially with the aged patients. And then some data already reported that the presence of CVD associated with increased mortality in COVID-19 infection. The other phenomenon that we know, we read from the journals, mentioned that in some part of world, let's say in northern Italy, already reported 58% increased in out of hospital cardiac arrest comparing in the same period in the last year. Also in France, I think Prof. Steck know better than us that they also reported the higher out of hospital cardiac arrest comparing in 2019. And even if the patient admit to the hospital, the survival is very, very low. In the United States, already reported that estimated 38% reduction in cath lab laboratory, especially for STEMI patients. And then we really appreciate some of us in Indonesia, starting in early of March, we're still doing primary PCI, even though we know that at the time we still very, very terrified, and then we didn't know exactly what to do because lack of information. And also at the time, the way we screen the patient is so bad. We just rely on the historical anamnesis from the patients. But now I think we're slightly better than comparing with the early of March. So we can see all the colleagues from Sumatra, from Java, and also from Sulawesi still doing primary PCI during COVID-19. So what about in Indonesia? So the data, we're still collecting the data from all over Indonesia, but still we behind the time. But anyway, I will try to provide you the data from my hospital in the Harapan Kita, National Cardiovascular Center. If we compare this line, comparison of total STEMI cases or admitted in the emergency ward, you can see in 2019 the red line showing the number is relatively stable between 60 to 80 patients per month. But if you look at in the recent days, you can see starting for the February, maybe the last week of February, they start getting down, and March and even the April, the the STEMI cases in us is around 50% comparing in 2019. In May also, but in June we hope that this number is getting better. The last information I received that is already reached, let's say, around 60 to 70% comparing the last year. So what about the STEMI management? Of course, we learned from the EC guideline. You know that Indonesian Heart Association copying the EC guideline, and then is already around Indonesia. We know that the STEMI management goal is how to reduce total ischemic time. And total ischemic time rely on the first the awareness of the patient, and then the ambulance system of the city maybe, and then we try to reduce the door to ischemic time by reducing door to balloon time less than 90. And I know the EC guideline mentioned it's less than 60 minutes, but in Indonesia I think we're still in. We hope we can reach door to balloon time less than 90 minutes. So the other thing that we face in Indonesia, and I also know regarding this issue, there's some fearness of COVID-19 patients, because EC report that more than half of the heart attack patients away from hospital, means that they still try to not to go to the hospital, and that could be fatal for the patient itself. So there's some reason for decreased ACS admission in our emergency ward. One of the fearness of being exposed to COVID-19, and then the second is some worriness about the burdening of the healthcare system due to this pandemic. And then the third one, maybe in some part the patient not leaving their homes due to the government restriction, maybe to the what we call it lockdown. And then we also know there is some changes. EC recommend us to do the pathway. If the patient come to ER access, so we must screening the patient whether the patient has a fever or respiratory symptoms of a history of previous contact with other COVID patient or any other family history of COVID infection. If there is no COVID, so the patient can go as usual or daily routine basis. And then if the patient has a COVID infection possible, that creates some problems. So if the patient need a hospital admission, so we must be sure whether we should put patient in special ward or COVID isolated ward or not. So it depends on the screening capability of each hospital. So what about in STEMI? So there is some extra delay expected. In Europe, they expect around 60-minute extra delay. Mean if you want to have a 120 minutes from the first medical contact to cath lab, so you must add around 60 minutes before the patient coming. Whether if the patient go for primary PCI or go for fibrinolysis. And also most important that any STEMI patient should be managed assuming positive for COVID-19 status. So it should be applied all over hospital, including in Indonesia. So again, even the EC mentioned that the COVID-19 pandemic should not compromise timely perfusion of STEMI patient. But even though we know that it's very, very difficult for us, because concurrently, we must be sure as well that safety of us, healthcare providers, should be ensured. And also we must be sure we must doing proper screening for each patient coming, especially patient with STEMI. So in the last week of March, the Indonesian Medical Association launched the protocol of COVID-19 management, but it is also 3 months away. So I think we must revise this protocol as soon as possible. So the protocol for each hospital is different. Indonesia also is depend regarding the screening capability of the hospital and also the PPE in each hospital. If you look, this is from just the example of my hospital. The patient coming, so it must completed epidemiology from inquiry form, and then you must, divided the patient whether asymptomatic or not. If patient COVID positive, sorry, in my hospital, we're still doing further analytic. If not, so all a patient must come in to the cath lab, and then after a patient got primary PCI, so the admission award rely on the rapid test. So this is also a journal with the 141 respondents all over the world, showing that 62% of respondents declare a STEMI patient presented later than usual. And then also in Harapan Kita, this is slide actually showing the same data. If you look at the right side, we have relatively increasing STEMI with more than 12 hours onset, especially in March. In April, it looked same, but you know that in April, the number of patients coming in emergency ward is really declined. So it's not really comparable. So in May also, you can see there's some increase in patient STEMI with late onset. The same thing also reported in Ireland, that there is some increasing in the symptom to first medical contact and total ischemic time. Same report also in insight from British Cardiac Society in some hospital in UK. But I must admire, even the ischemic time is increasing, the door-to-balloon time in those hospitals is still good comparing to the before COVID area. I think not every of us can achieve that number. If you look at the ischemic time STEMI in my hospital, comparing it to the last year, we can see there is some increasing ischemic time significantly starting in March and April, and then it's going to be better in May and June. So what about the door-to-balloon time? It's affected so much because we still try to find how to decrease the door-to-balloon time in the matter of how to screen the patient as fast as possible. So right now we just rely on the historical taking and also to the rapid test. But if you look at the door-to-balloon time in my hospital comparing to the last year, you can see the comparison is almost 4 times or 5 to 4 times higher in terms of door-to-balloon time. So mortality, I think maybe is not comparable, but I've mentioned before the number coming in these 3 months is really declined. And then if you also, we must put in mind in patients with coronary artery disease and heart failure, because patient will coming in the late stage, maybe at a particular risk as a result of coronary plaque rupture, secondary to viral induced systemic inflammation. And we need rigorous use of plaque stabilizing agents like aspirin, statin beta blocker, ACE, or whatever that our usual guideline mentioned. And then we know due to the systemic inflammation happen in COVID-19, so we also like to intensify our antiplatelet therapy in those patients, especially patients STEMI underwent PPCI. So of course there is some also discussion about the role of corticosteroid, but still we need more data regarding those issues. So this is my last slide. We know that there is no single solution for all invasive services and networks in the COVID-19 pandemic, including in Indonesia. So there will be a variation of the restriction according to the stage of the crisis. And then we know all over the world, patient presenting, STEMI presenting in our emergency ward must be had a longer total ischemic time, might be driven by delay from onset of symptoms to first medical contact because the patient really hesitate to go to the hospital. and then also the potentially due to the isolation or reluctance to engage medical services due to fears of regarding of COVID-19. I think this is my last slide, Dr. Bambang. Thank you very much for attention.
Yep. Thank you very much. Thank you very much, Dr. Doni, for the wonderful talk and very informative. The Q&A will be done after the second lecture. And then I think Dr. Sunaria will be chairing the next talk. Please, Dr. Sunaria.
Thank you, Dr. Bambang Budiono.